Okay, fantastic. Well, good morning, good afternoon, good evening, everyone. And my name is Anjali Atraker, for those of you who don't know me, and I'm so privileged to be serving as the acting U.S. Global AIDS Coordinator. And really, on behalf of our entire team over here at the Office of the Global AIDS Coordinator, and on behalf of the USG, I wanted to welcome you today to our PEPFAR Strategy Vision 2025 listening sessions. We're handling all of these listening sessions. It's something we've never tried before, but what we've been doing over the past several days is hosting a number of listening sessions by stakeholder or constituency. And so you can see we've met with multilateral and private sector and foundation partners. We've met with civil society and communities. We've met with partner governments, including ministries of finance as well as ministries of health. We've met with a number of implementing partners across all the various portfolios. And today we're thrilled to have our Scientific Advisory Board with us. On Monday, we'll have a US government-wide meeting, but again, they've been virtual listening sessions that have been so rich in discussion and feedback. The format of each session has essentially been a brief epidemiologic and PEPFAR overview, which we'll provide today. And then we have a facilitated comments and reflections session, and that's really the majority of the entire session. It's important for us to hear from you to help guide us as we move forward and develop this strategy together. And then we'll summarize the key themes that we've been hearing toward the end of the session. All of these sessions are being recorded. We will be posting them on our website, and we will be sharing these slides as well. So moving into the global HIV/AIDS situation, just wanting to share some key epidemiologic trends. Here we see the global HIV/AIDS situation with significant declines in new infections and deaths since 2003, thanks in large part to the collective effort we've been doing together, and with a number of high-burden countries getting to a point of epidemic control. And scaling tremendous HIV prevention and treatment programs, we're really seeing these collective results. Looking regionally, here we see Eastern and Southern Africa, and this is the region that we're really seeing the most significant epidemiologic impact. These are all a series of UNAIDS graphics, and what you'll see on the top are declining new infections. Again, new infections and deaths declining across the top. On the left corner, you'll see the distribution of new infections by population. The next graphic are the resource availability and the needs over time. And then finally, the cascade as well as gaps on the right. Again, here, thanks in large part to a number of high-burden countries getting to epidemic control, we're seeing these incredible dramatic decreases. Here we see Western and Central Africa. Again, the same sort of pictorial graphics, but differing trends. We still see continuing declines here. We see the distribution of new infections, predominantly among key populations and clients of sex workers and partners of key populations. Here we see resource needs growing. Here is the Asia and the Pacific region with continuing declines, as you can see in the top part of the slide, and then the distribution of new infections by population, predominantly in concentrated key populations, with resource needs increasing. And here we see the Caribbean, again, declines that we see across the top, and then again, the distribution of new infections by population on the left, and then resource needs also increasing. In Latin America, we're seeing a relatively steady state, as you can see on the top part of the graph, with the distribution of new infections along the bottom left, again, predominantly among key populations. And in Eastern Europe and Central Asia, we see increasing trends, increasing new infections, increasing deaths, new infections concentrated among key populations, resource needs increasing, and again, a real need for implementation of evidence-based policies and practices to really impact the region and drive those same kinds of declines that we're seeing elsewhere. What has remained consistent is the truly unwavering bipartisan congressional and presidential leadership of PEPFAR since its beginning from 2003 into present day. The current administration has been so supportive of PEPFAR in these past months since January, which has been, again, a real testament for their belief in PEPFAR and their continued support. As you know, PEPFAR provides support in 55 countries, and this graph shows the burden of disease, and we've aligned our investment to the HIV burden of disease. Looking at a summary of PEPFAR's latest program results globally, we see that we have 18.2 million people, women, men, and children on life-saving treatment. This is an additional 1 million in the past 6 months alone, and this is reflective as of fiscal year 21 Q2 data. Again, a large reason for this is a lot of the adaptation that the country teams, the implementing partners, the governments and communities have been doing related to multi-month dispensing, to decentralized drug delivery and other critical interventions. We also see 26.8 million circumcisions that have been completed. Again, this is as of fiscal year 21 Q2, and other indicators listed here. You've seen this graph before. This just updates it with our latest fiscal year 21 data on the rightmost part of the chart. But here we see trends of the PEPFAR budget over time, so since the beginning in the blue line. In yellow bars, we see cumulative circumcisions, and in blue bars, we see the current on treatment. Again, increasing trends despite a flat budget. And as I noted earlier, we only have Q2 data reflected here, up to Q2 data reflected here. So we'll be updating that with the subsequent quarters. Our commitment to treatment continuity and growth remains consistent and strong, despite the peaks in COVID-19 transmission, as you can see in the peach graph here. And we continue to see several countries making tremendous progress toward the UNAIDS 95-95-95 goals. These are select countries in Southern, East, and Western Africa. And you can see these are countries that have completed the population-based surveys, and the results are indicated here. Again, progress along the treatment cascade, and in orange, you can see the community viral suppression. We've made strides together in many of our public-private partnerships. This one in particular, DREAMS, with the work that we're doing on preventing new infections among adolescent girls and young women. And we continue to make strides and progress, but also see critical gaps that we need to fill related to our programming for key populations. Here you see programming by key population, and you see a full cascade, including prevention indicators and PrEP. We're going to go through these next series of slides fairly quickly, but wanted to show countries that are at epidemic control, those that are nearing epidemic control, and those that are having declining new infections, but still not yet at epidemic control. So and a big thanks to UNAIDS. These data are and much of the data throughout this deck is from UNAIDS. So again, sort of flipping quickly here, we see a number of countries at epidemic control of HIV/AIDS: Zimbabwe, Kenya, Malawi, Lesotho. Here we see Ethiopia, Rwanda, and Eswatini, Thailand, Nepal, and Cambodia. Burundi, Cameroon, Cote d'Ivoire, and DRC. Burkina Faso, Senegal, Togo, Mali, Liberia, and Trinidad and Tobago. And then we'll see a number of countries nearing epidemic control of HIV. These include Botswana, Haiti, and Uganda, Vietnam, and Guatemala. Countries with declining new infections but not yet at epidemic control include Angola, Ghana, Mozambique, Nigeria. Again, looking at new infections and total deaths. South Sudan, Ukraine, Tanzania, Zambia, and South Africa. And again, here I just want to note that the y-axis obviously is very different across all of these graphs. Another series of countries not yet at epidemic control include Tajikistan, Indonesia, Panama, Guyana, Jamaica, Dominican Republic. Looking at gaps, opportunities, and what the end state might look like. Again, showcasing really important data from UNAIDS in terms of distribution of new infections by population, looking globally as well as in particular regions in sub-Saharan Africa, as well as the rest of the world, as well as the distribution of new infections by age and sex. I want to make two critical points here. One, in sub-Saharan Africa, despite the gains that we've just looked at, 52% of the new infections are among young women aged 15 to 49 years old, even though they account for only 24% of the population. So continuing to decrease new infections in this population is critical, particularly as we think about the youth bulge that exists. Second, there's variability of coverage and access of critical HIV prevention services for key populations across countries and regions. So we must continue to focus on these key populations and address barriers. Here we see coverage of ART by adults in pink and children in orange, and these are trends across the past 10 years from 2010 to 2020. And two key points to make here. 40% of children living with HIV had suppressed viral loads in 2020 compared to 67% of adults. And nearly 2/3 of children not on treatment are those aged 5 to 14. So again, a gap here where we need to focus. COVID continues to be a vulnerability affecting the program and the beneficiaries we serve through PEPFAR. However, for the past 18 months, we've been adapting the program, real-time adaptation, to really protect the gains, but not only protect the gains, but to accelerate through COVID-19 and also to strategically utilize the platform that exists to respond to COVID-19. PEPFAR really does offer a care delivery platform. We've invested significantly since the beginning of PEPFAR in a number of health infrastructure and system capacities, including over 3,000 labs on the continent of Africa, access to clinics and data and patients in over 70,000 healthcare facilities around the globe, nearly 300,000 healthcare workers, including community health workers, through PEPFAR support, as well as robust commodity supply systems that, again, have been leveraged and continue to be leveraged to respond. Here we see HIV investments by funder in PEPFAR-supported countries. In red, the PEPFAR investment, both in actual dollars as well as percent. In blue, the Global Fund investment. And in gray, the domestic government investment. In orange, we see other funders. And here we see projected gross domestic product growth versus HIV prevalence rate. And here, it's important to note that we continue to see economic problems from COVID across the board, but worse in countries with high HIV prevalence, as you can see in the red dots, as well as countries with mid to higher income status toward the right side of the graph. One of the key components, as you know, to our approach to sustainability has been sustaining delivery of HIV services through local and community partners. We currently have 55% of new funding going directly to local partners, and that's in blue across all three graphs. And you can see this 55% in the leftmost graph going to local partners. But this varies by portfolio. So what you see in the middle is care and treatment. Again, the amount of funding or the percentage of funding going to local partners in blue, and then you see prevention in the rightmost side of the graph. And here we have less than 40% going to local partners. So looking into the future, and what does a sustained response look like? A sustained response might look like this, with a whole of domestic approach from government to community to successfully sustain epidemic control of HIV, with sufficient functional, technical, and managerial capacity to maintain the scale of key programs and services stewarded by local and community partners, financially sustaining essential services and prepared to meet emerging needs, HIV service delivery integrated into broader public and private care delivery systems, a robust public health response in place to monitor and track new HIV infections as well as emerging threats, and quality assurance to effectively manage and monitor services to ensure positive health outcomes. So this brings us to why we're here today. With that backdrop and that context, discussing the PEPFAR 5-year strategy development and really seeking your input. We began the development of the next PEPFAR strategy late last fall, in fall of 2020, and we want to thank you and the many of the other hundreds of stakeholders that have contributed to this strategy thus far, from last fall through to World AIDS Day and today, with a number of the listening sessions that we've been hosting this summer. These inputs are not only critical and feeding directly into the strategy as we continue to develop the strategy for the next 5 years. It also your feedback feeds into the Country Operational Planning 2022 guidance that we'll begin developing later this summer and into the fall, again, circulating and continuing to seek your input, as well as our longer term planning as we move into the future. The proposed strategy, Vision 2025, is really focused on achieving sustainable, equitable, and resilient control of the HIV/AIDS epidemic, continuing to support global efforts to put countries on track to reach the Sustainable Development Goal 3 target. And again, ensuring that there's close coordination with the Global AIDS Strategy 2021 to 2026 that was recently released by UNAIDS and adopted by the various countries, as well as the post-22 Global Fund strategy that's currently in development. Now, I won't read all of these objectives. You all have received in PDF version this, as well as some additional details in terms of the goals and the objectives. But just to note, we have 3 proposed goals, and here with goal number 1, to accomplish the mission 95-95-95, sustained, equitable, client-centered HIV prevention and treatment services, we have a series of 6 proposed objectives as listed here. Goal 2 is to build enduring capabilities, resilient and capacitated country health systems, communities, and local partners, with 5 proposed objectives listed here. And finally, goal 3, to broaden the base of support, partner for greater impact, burden sharing, and sustainability, with these 5 proposed objectives listed here. We've asked that you all, as well as all the others that we've been listening to reflect on a series of questions. These questions are listed here. At this point of the session, I'm going to hand it over to Surbhi Modi from CDC and Bob Ferris from USAID, as well as Sarah Clucking from SGAC, who will facilitate the next and really the majority of this session. So Sarah, Serby, and Bob, over to you.
Thanks so much, Anjali, and welcome everyone. I'm really pleased to be here with you today. I'm Serby Modi, Principal Deputy at CDC's Division of Global HIV and TB, and excited to be here with my interagency colleagues, Bob Ferris from USAID and Sarah Clucking from the Office of the Global AIDS Coordinator. We're really excited to hear from the members of the PEPFAR Scientific Advisory Board today. With such a broad group of stakeholders represented in this board, representatives from academia, partner governments, multilateral and bilateral institutions, faith leaders, non-governmental organizations, among others, your role is critical in advising on scientific implementation and policy issues. And so what we'd like to do for today's session is have about 15 to 20 minutes for board members to share their perspectives on each of the 4 questions that you all received by email before today, and that our colleague Juliana Houston has also posted in the chat. So we'll start with question 1, and what I'd ask you all to do is please raise your hand, and then we can just go in order. You should be able to unmute yourselves. The first question that we'd like to start with is about the PEPFAR strategy, Vision 2025. This is aligned to the Sustainable Development Goals and Global AIDS Strategy. Are the draft PEPFAR strategy goals and objectives the priority areas for the program to address, and are any missing or in need of refinement? So we'd love to hear from you on how you think the strategy has done in addressing the priority areas for the program, what's missing, what needs to be refined, and what do you think is really critical to bring forward? Looking for raised hands.
I can see, I think Ken and Albert have their hands raised.
Okay, great.
Yeah, good morning, good afternoon, good evening. I think the strategy looks good. I think there are 2 areas where I wonder about a little more granularity. I mean, the investment in prevention is really paying off, and it's really laudable. But you know, when you have you still have this large number of people living with HIV, and I'm just curious about the granularity about investment in health system strengthening, particularly for management of comorbidities, as we know that's going to be a major set of issues as the population ages. I think, you know, it's certainly more than a third of the African population now are over 50, and it'll start being similar to our graying pandemic in the US and more resource-rich environments. And then the other issue is the elephant in the room. How robust do you think PEPFAR is to become PEPFAR? Because I do think that we really, you know, you have such a wonderful infrastructure and addressing what additional investments can be made. And there already have been some, but how much more can PEPFAR be leveraged to address the need to get everybody vaccinated globally?
Thank you, Ken, for your comments. So let's go to Christine next.
Thank you very much. From my side, I'm not sure that
Christine, I think your line is breaking up.
Serby, I wonder if we can come back to Christine because she's breaking up. I see Albert and Mitchell and Croatia.
Chris, we can't hear you, so we'll come back to you in just a few minutes.
Okay.
All right, maybe we can go to Albert next. Okay, Christine, apologies, we are not able to hear you, so we're going to go to Albert next, and we'll try to come back to you.
Thank you. This is Al Siemens. First, wanted to just congratulate the entire team that's worked on this plan. I think the process has been fantastic, and I think you've come up with the substantive direction for the future. So great job. Just wanted to emphasize, in essence, what Ken Mayer has just said as well, to really emphasize prevention in the future. While the definition of control is good and it's certainly driven a lot of success, I think the emphasis on prevention, particularly in key populations and in young women and young men, is critically important, and certainly leveraging technology, but then also getting to the social dynamic that's so vital. Regarding that, which sort of includes stigma, discrimination, inequities, and so on, I know this is a point that comes up later, but just wanted to emphasize that I think your intent to work with local stakeholders, local opinion leaders, voices that are respected in local communities or within specific populations is vitally important for the prevention program to be successful. Now, we're living that in the United States right now with COVID vaccinations. And the importance of local trusted voices, I think, is critically important. Finally, I would just say, while the plan is fantastic, I would be careful not to overstate intent or expected outcomes. There are words like ensure, innovation, institutionalize, capacitate. These are big, powerful words, and I think it's really important to qualify those intents, such as help ensure or help facilitate. I think helps you perhaps underpromise but over-deliver at the very end. So congratulations. Thank you for giving me the opportunity.
Thank you for your comments, Al. Really important points. Let's move to Mitchell next.
Hi there. Well, good afternoon, morning, evening. I see people from all over the world, which is great. And Anjali and the team, thank you for bringing us all together on this particular call for the advisory board. And just really thank you for doing such an amazing job in keeping the program going so strongly, but also in, I think, what I regard as a really good outline for the strategy. My comments are actually very similar to what you've heard already. I almost put my hand back down after Ken and Al, but maybe just to underscore two quick things. Overall, I was really happy to see the framework for the goals and objectives, really like the people-centered approach that you prioritize very clearly in that first goal. I would just encourage us all to be a little more specific, particularly around, and this won't surprise you coming from me, beyond just embracing innovation. I'd really like to see, even just as in the objective, more specificity around what it means to really accelerate the way in which these new approaches will be brought into the program. And if I look at oral prep, where you all have been remarkable leaders, we're still, 9 years since the FDA first approved a product, and frankly, we haven't gone as quickly or as effectively as a global community as I think we need to. I would really be specific that we are going to, in the next 5-year strategy, ensure that new innovation is taken to scale much more rapidly. And I think it's implicit in the embrace language, but I think that language could be more explicit. And the second point, I think, again, building on something Ken started, I think the idea of the PEPFAR platform, which is just remarkable. And I think those working within PEPFAR or adjacent to it, as many of us are, really can't imagine global health infrastructure without PEPFAR. And while that third goal does talk about broadening the base of support, I think a lot of it's implied there in terms of the connective tissue and the way in which it can contribute, whether that's to the COVID response, but I'd love to see it more broadly in the same way that PEPFAR has been really at the cutting edge of HIV and TB integration. I think there are a number of ways, again, without losing focus, without getting off mission, which really does need to be epidemic control. I think there's a way to be more explicit about that. And the third point, just I'll make very quickly, and it may come up later, is the definition of epidemic control. And Anjali, your slides are terrific in showing where countries are, and some having already reached it, some near and some further away. I do think how we think about sustainable control, again, you know this and do it already, but I think the strategy could do a really great job in helping galvanize other partners to confirming and aligning around definitions of epidemic control and sustainable epidemic control. I worry gravely about tipping backwards in the current environment. So I think that would be an area I'd love to see that kind of, again, fine-tuned. I don't think any of this is that the strategy doesn't say it. I think it's just a matter of more explicit and more specificity, which I know will come, but really great work.
Great, Mitchell, thank you for adding those points. Let's move to Croatia.
Greetings, everyone. Thanks, Surbi. So I'm not going. I just wanted to echo the sentiments made already in terms of congratulating Anjali and the team and the partners for the continued amazing progress in the HIV response, despite the challenges of COVID. I've always been impressed and admired the way all of the evidence is presented with data, and particularly in your presentation, Anjali, how you've captured the returns on investments in HIV for the COVID response. And I think that while the strategy is written very carefully and the objectives to be broad and not too specific, because sometimes there's this very fine balance about how much specificity you put in. I do think that they are HIV specific issues that need a bit of expansion. So, for example, if we're going to use the SDG framework, you know, it's all about inequities and inequalities. And the health SDG 3 only focuses on one component. And I think when we think about who we are leaving behind and what are the gaps that need to be filled, we do need to address those very core structural challenges that face us in I think a more concerted way in this next period of strategy implementation. And you touch on it on question 4 in terms of stigma and so on, but vulnerabilities across the globe is so fundamentally rooted in racism, in gender inequalities, in the overarching poverty that makes some populations more vulnerable than others, that I think it behooves the group to look at the other SDGs that could complement our attainment and bring more synergy to what we can accomplish just through SDG 3. The other point that I wanted to make was, again, one of these balancing acts. And I think it was really very informative how you laid out different countries and different regions in terms of what they've been able to achieve in terms of epidemic control, where you reach it, where you're close to it, and where you're off. And I guess the balance would be how you prioritize investments and resources and finances, both resources and finances rather, in terms of getting those countries where we're seeing new infections really taking off with those countries where you've already invested a lot and are still off track, versus sustaining those countries that have already achieved things. And then lastly, mission creep is so easy, but I wanted to go back to my first 2 points, which is the sort of resilience of PEPFAR and the entire program and partnerships of keeping us on track with HIV. But at the same time, how those investments have been used for COVID-19. So echoing the previous speakers in terms of the opportunity, maybe make the new point, but getting to this convergence and colliding epidemics and pandemics that occur and not dropping one while we continue to see the challenges. Some emerging data, certainly from South Africa, where we see COVID-19 variants of concern emerging in HIV-infected persons who either have therapeutic failure or who've not yet been initiated on antiretroviral treatment. And we see this emergence within days and prolonged viremia, COVID-19 viremia in these patients. And so it provides for me an excellent opportunity where we bring these two pandemics together, because the more we strengthen our HIV response and the more we get to our targets for HIV for 2025, the stronger it makes our COVID responses. And our COVID responses has to build on the HIV investments and make available the PPEs, make available the vaccines, but also continue to show how a strong HIV response could have global benefits in terms of mitigating and minimizing the emergence of variants of concern. I am sorry I took a little bit longer than I thought I would, but thank you. That's it.
Thanks for those important points, Croatia. Let's move to Jesse.
Well, thank you so much, and congratulations for this strong update and this very robust strategy. And it's good to meet you, Madam Coordinator. I'm Jesse Milan. I'm the President and CEO at AIDS United and a person living with HIV. And I simply want to expand on the comments from Mitchell and Dr. Siemens and Ken Mayer, that particularly for Goal 1, the code words of people-centered and equitable and meeting people where they are, I think should not be mere code words for specifically addressing stigma and discrimination, particularly for especially marginalized populations around sex workers, LGBTQ people, and people who use drugs globally. Addressing specifically the words and the challenges for changing the social and political environment for people living with HIV, I think needs to be elevated in the objectives. Even with just the use of those words, I think would remind us that those are barriers for people-centered care for key populations and for getting people to not only embrace but support people for their long-term life as people living with HIV. So I would urge those amendments, especially in the statements related to objectives 1.1, 1.3, and 1.4. Thank you.
Thank you, Jesse. Angela?
Thank you very much, Subi, for giving me this opportunity, and thank you, Angeli, for taking us through those slides. I am speaking really in terms of advocacy for children and as well as advocacy for women living with HIV and elimination of mother-to-child transmission of HIV. And in that subpopulation of women, particularly focusing on the young women that are contributing, like in my setting, more than almost 50% of new child infections coming from the young women, so adolescent girls and young women. And therefore, I think that in the goals and I was looking at the UNAIDS strategy on ending inequalities. It would be so nice if there could be something speaking to vertical transmission or elimination of mother-to-child transmission of HIV. I know that we have spelled out prevention, which is brilliant, it's excellent, but I do think that we should probably focus and bring it out in the language. I don't know how that is going to be done, because in the same UNAIDS strategy, they do have a priority area, which is, I think it's result area 3 of the UNAIDS strategy, which actually articulates those subpopulations. What I found programmatically, if we are just focusing on prevention, automatically, the prevention side is more towards the sexual prevention, and yet from the slides that you have presented, you've actually shown us the inequities for children. And I think that is very important to bring out. My next point probably touches on some of these structural determinants, such as gender or stigma and discrimination, and how they can also come out in the strategy. And then lastly, it's really a question: how are we situating the strategy in the context of universal health coverage? And then how are we going to tackle the issue around integration? Thank you very much.
Thanks, Angela, for raising those new points. And let's move to Connie and then to Carlos, and then we'll switch to question 2. So Connie first.
Sure, thank you. Again, my congratulations for doing so much in the challenging times of COVID. It was impressive to see that the progress actually in meeting objectives. I just wanted to come back to the topic of prevention and to say, to me, it seems that there's a real opportunity to build on some of the successes really in PEPFAR during COVID of moving to multi-month dispensing, to build on that approach and the client-centered approach of to reach key populations better, and that there, I want to echo Mitchell's sentiments around, I feel like with oral PrEP, it's an imperfect tool, but it has been very, very slow in terms of adoption in many countries. And even though there are guidelines, the number of people being reached is small. So I feel like there's an opportunity to build on key population efforts to have higher goals for reaching them with PrEP, and to do that by strengthening the amount of funding and the capacity of local partners. It seemed like on that one graph you showed that PEPFAR has done that less with prevention, but I think if you're really serious about trying to improve the proportion of key populations and adolescent girls, young women who are receiving PrEP, the way to do that is through local partners, building client-centered programs, and multi-month dispensing. Make PrEP easier to actually initiate and persist with. So I think those are my main points. Thank you.
Thanks so much, Connie, and over to you, Carlos.
Thank you, Angelique, and thanks to everybody working at PEPFAR. I know it's really difficult, especially during times of COVID, and the fact that you have to continue doing your work is really important. I think the plan is really good. It's ambitious and as it needs to be, and it really is striving to really change the course of the pandemic. I think one area that we need to put some emphasis and focus is on training, healthcare workers and building healthcare work capacity, because I think that's one area that I see us potentially falling apart. At some point in time, somebody has to do this, and we need to figure the workforce as one of the key components that has to be tackled. And what the strategy for that is, I think, is going to be something that needs to be, outlined. Thank you.
Great. Thank you all so much for your feedback into question one. And I'm going to hand off to Bob now for the next question.
Serby, thanks so much. Good morning, good afternoon, everyone. Bob Ferris, I'm a Deputy Principal for USAID and the Chief of our HIV Prevention, Care, and Treatment Division. Our question number two, good to see so many of our SAB members this morning, this afternoon. In question number two, we're really asking, what does PEPFAR program look like at sustained epidemic control of HIV? And second, what are the main threats to maintaining epidemic control of HIV? We've heard about COVID. Are there other threats? And if on COVID itself, are there any other specific things that you'd like to address that would help us maintain epidemic control? Why don't we go to Jesse? I see your hand up first.
Sorry, that's from the last round. So I'll take my hand down. Thank you.
Great. And Carlos, I see your hand. Is that an old hand or a new hand?
That's a very old hand.
Okay. So again, what does the PEPFAR program look like at sustained epidemic control of HIV? And what are some of the main threats to maintaining epidemic control of HIV? Okay.
Carlos, I'm going to raise a new hand.
Okay, go ahead.
I mean, I think the major threat that I see, I mean, there are many threats, but I think to me a major threat is lack of political, sort of priority and focus and interest. And there are too many distractors out there, COVID being one of them, but there are many other distractors out there. And if you lose, your political drive, focus, interest of this being a critical global health delivery program, then it starts slowly to disappear and become just not a priority. And that would be my biggest worry that I have is, again, I so many times I hear people, going to Congress and people say, well, we thought HIV was over, it's done, that's not a problem anymore. And I just worry about that being the biggest threat.
Thank you, Carlos. Albert, can we get your thoughts?
Sure, this is Al. In a way, when Carlos started commenting, I was going to take my hand down too, but I think clearly I have to endorse what he has said. I think it's always competing issues that are going to be a threat, whether it's COVID or it's something else. But further, going back to Carlos's initial comment about training healthcare workers, while I certainly am aware that PEPFAR has put a lot of effort and money into training community workers and so on, healthcare workers, I think some emphasis might be placed on getting proper training into healthcare curricula. I know one of the topics that you're considering is, the integration versus stovepipes. And to the extent that national curricula would include, that is for healthcare workers, would include HIV/AIDS and all of those technological as well, medical and sociological challenges, I think that would be a valuable step forward, because the other significant threat is the sociological political dynamic. Again, Carlos has mentioned that. I think this is going to be the continuing struggle, particularly as we work across multiple nations that are struggling with all of these different challenges. Thank you.
Thank you. Mitch, over to you.
Thanks, Bob, and great to see you. I'll just, underscore all of that. Just don't declare success too soon. I think the desire to reach epidemic control is obviously the right thing to do from a public health perspective. I think politically, it's a way to move to the next issue, and so many competing priorities. So I think it's important to define what we mean by, and it's interesting, sustained epidemic control. Is that, X number of years where you see epidemic control, and at what point do we begin to see a complete diminishing of focus and the chance for it to bounce back? And I'm just very struck. I just read earlier in the last couple of weeks, Peter Sands wrote a really great piece about pandemics and the fact that we don't call certain diseases pandemics because they don't affect our countries in the global north or in wealthier countries, and therefore it's no longer a pandemic. And I'd hate to see us get to a place where HIV becomes the challenge in a handful of countries, and we no longer can make that case. So I would just say again, don't declare success too soon, and be sure there are very clear measurements for what we mean by sustained epidemic control, so that we really are able to secure that.
Thank you. Croatia.
Thanks very much. Just to underscore the messaging issue, because I think somehow in public health we don't always get it right. And we saw when we set the 2030 target of ending AIDS as a public health threat, it went off many people's radar screens. And so I think complacency for me is something that we have to be very mindful of, particularly in countries where we're saying we've achieved epidemic control. And I think we don't know enough about durability. So while those curves are looking good, I think COVID again reminds us about waves and don't get too complacent. And then the other, which is, that balancing act we need to do in terms of investing more energy and effort in the countries that are off target and getting them back on track, is how do we do that while ensuring we don't drop the ball? And to underscore that while we're doing great on treatment and we're doing pretty well on PMT, CT, I think on prevention, it's our big challenge. And I think in this next phase, that's going to be like a very high priority. It's more complex than we think, but it's not something that's not within our grasp if we set our minds to, but we have to be prepared for that complexity of how we need to respond to preventing new infections. Thanks.
Thank you. Ken, over to you.
Yeah, I endorse what my colleagues have said. The two other things to consider: it was very encouraging to see the increasing in-country investment in some of the countries, which I think is great. But I think that's an opportunity for PEPFAR, and PEPFAR's been great up until now, to be innovative and think about how to use the appropriations to leverage other issues that may not have been as fully addressed. And I do want to keep coming back to this issue of the graying epidemic, because again, epidemic control with lots of morbidity is not necessarily the optimal outcome. So I think there's opportunities to repurpose some of the funds in places that are doing a good job and where the country is stepping up to the plate. A different comment is that another change in the epidemic, because of increasing epidemic control in a generalized epidemic, is going to be the disproportionate contribution of key populations in some of the countries. And I think particularly given the current focus of the administration with much more of an emphasis on human rights than in recent years, I think thinking about how OGAC can leverage its substantial investments and excellent relationships and infrastructure to ensure that civil society feels engaged, because certainly a great way to have resurgence among the key populations is to drive behaviors underground and to facilitate less than optimal social policies.
Okay. Bill Pop, let's move to you.
Thanks for this opportunity. I think the program is great. It addresses a lot of global issues, but I think that it lacks some specificities, particularly related to sexually transmitted infections. We see that STI are not well controlled throughout the world. And I think this would be a major threat to the program, except for circumcision, which is making good progress. I think that this should be more properly addressed. Another major disease very much associated with HIV is tuberculosis. We know now that it's the #1 cause of infectious disease in the world, and it's so closely related to HIV that I think it would be a missed opportunity not to look at that. A third one, not infectious this time, it's cardiovascular disease. If you look at a lot of those countries, the #1 cause of mortality is no longer HIV/AIDS, it's cardiovascular disease. And many of our patients are having cardiovascular disease. So that also should not be overlooked. Finally, if you look at all our populations, those who are most affected, they are poor people, they are key populations, and they have in common the fact that they are marginalized. So we should have a way to empower them through some form of global health services. I'll stop there. Thank you.
Much appreciated. Great comments so far, everyone. Lejeune, over to you.
Yes, good morning, good evening, everyone. I have a sort of a list of things that many of them were already commented on, but I just wanted to reemphasize. So the political instability most definitely poses a threat to maintaining epidemic control. A lot of this can be, related. We see this with diversion of funds from the healthcare sector during political campaigns and, and changes in leadership. The other is the economic instability, which really affects the availability of commodities. So drugs, test kits, reagents become scarce. The other issue of social issues related to culture and other norms, like for example, in many places around the world, it's still taboo to even talk about sex, in homes or in churches or places where people gather, where we want to reach individuals. The other is the technology. So the lack of technology in many countries, for example, poor cell phone service, internet, makes telework, which is really necessary in times of COVID, to be very difficult to implement. The other is the sexually transmitted infections, which someone already just mentioned, that the fact that we're still seeing these infections, being very prevalent means that some of our prevention strategies are not quite working yet, or people aren't adhering. So that's an ongoing threat. The unwillingness for people to take PrEP because they don't understand it or there's misconceptions around PrEP is another ongoing threat to not be underestimated. The fact that with COVID, one of the I'd say ongoing threats that we see is that people have less interactions with healthcare personnel, and this can, have a longer, far-reaching impact that we may not be able to understand today, but that could be a bigger threat moving forward. And then, along the same line of infrastructure issues, the fact that many people around the world still have to travel long distances to even access healthcare services. So that, again, is an ongoing threat. Thank you.
And thanks again, Lejeune. We've got about 3 speakers left for this second question, and then get ready for question number 3. Let's move to Angela.
Thank you very much to comments, which I fully agree with. I think that one of the challenges really with epidemic control is complacency. And this complacency can be, yes, at a country level where we think, oh, we've done it. And then we get the foot off the pedal. And then we can bounce back or rebound, actually. We can slide backwards in terms of our indicators. I guess the other complacency might actually speak to the funding aspect, where people then think, look, there's no need to increase investments in that area because we have reached sustained epidemic control. My other point was, when a country reaches sustained epidemic control, What does that mean in terms of transition? And by transition is basically saying, well, we might have been receiving X dollars from PEPFAR. Now that we've reached epidemic control, what happens to the funding? And I want to highlight the issues around the health system strengthening component that has been supportive to countries through PEPFAR. What happens to that support when we are looking at transitioning and possibly sustainability? I like what Lejeune mentioned in terms of with COVID-19 and the pandemic raging across, how we have had to do things differently, how we've had to cancel using, technology, how we've had to reach out and support retention, adherence through use of technology. And yet in a lot of our countries that are high burden, the technology platform is not robust enough to really support, including in the most hard to reach areas. And then my last point, which I think is a threat, is the humanitarian crisis. I think we've seen the floods, the fires, and I was listening to a virology webinar. I think it must have been the International AIDS Society, and there was a session on the triple pandemics of HIV, of COVID-19, and climate change. And I think that is really another threat that we have to deal with. Thank you very much.
Thank you, Angela, and particularly thank you for mentioning the triple pandemic. Let's move to David.
Thanks, and start off by echoing support for, congratulations on the strategy and comments so far. I think in terms of sustainability, I think it's important to recognize that PEPFAR has actually done pretty well so far in terms of sustaining meaningful activities and benefits over time. And we should try and, I think, build on that. So one question I would have is if the program has a theory of change around sustainability, and particularly around the integration convergence agenda in particular, because I think that might benefit in terms of operationalizing some of the strategies put in place. I would agree with the notion of trying to emphasize the political support for future sustainability. I think that's important not just among political elites, but also in civil society, business, and particularly among communities that have been left behind. The other area I think around sustainability is really around the need for continued program adaptation. And here I think the biggest challenges in adaptation are addressing some of the underlying challenges, as well as on that integration or convergence agendas. So for example, and I think it's good on the convergence agenda to organize it around people-centered and being able to be more ambitious without losing the mission. I think there's different things that need to be worked out probably at country level and cross-learning around what that looks like at service delivery level, moving beyond just the convergence of HIV and TB integration, maybe more with chronic diseases, but also I would say lots on the public health capacity building. That's also critical. And again, some good directions that are proposed on that. I would say the even greater challenges around addressing some of those underlying social and structural barriers, and we've heard around them: gender, race, poverty, power imbalances. I would agree with the the driving trends around aging and demographic epidemiologic changes that are affecting populations, but also rapid urbanization. And I can't highlight enough the health emergencies and disaster and our inadequacies in those areas. And many of them are man-made, climate-related, but also emerging infectious diseases, and they're quite connected. Now, how to do that without losing the mission on HIV related services, I think, is really the trick. Let me just end by saying that, in addition to some of the structural issues like service delivery and health workforce, absolutely, there are some important upstream issues around global common goods that cut across some of those underlying threats. I think that relates to access to technologies, medicines, vaccines. I think PEPFAR has made some incredible wins, leading edge in terms of access to services, medicines, and diagnostics. But that needs to be a much more broadened and institutionalized issue that goes beyond specific pipeline programs. And we need a lot more change in that area for sustained HIV services and more broadly for sustainable health systems. Thanks. Over.
Thank you, Peter, and particularly about humanitarian efforts, global public goods, and a theory of change. We're going to change now over to you, Serbi, for question number 3. Serbi.
Of course, I'm muted. Sorry about that.
There you go.
Was
Thanks
just
very
saying,
much.
Was just saying that we've heard a little bit about the topic of question 3. You'll see it again in the chat. But how should PEPFAR plan over the next 5 years to mitigate the effects of COVID-19 and accelerate towards reaching sustainable, equitable, and resilient epidemic control? And how should PEPFAR continue to leverage its platform for broader health outcomes? I've heard from several, already that this is seen as a need. Who would like to say more about this question? Christine, I see your hand up. Let's see if you can unmute yourself. Christine?
Can you hear me now?
Yes, yes. Oh, well, we heard you for a few seconds. Christine, please try again. Okay, I'm still not hearing Christine. Are there others?
I would mention that for the first one, there was the issue of dreams. I would be interested in hearing more about the continuity of the dreams program. COVID-19, definitely, we have seen how HSS, health systems strengthening, is still a gap. And further magnified the challenges. And the approach to local policy continued support to in the interim, and integrating COVID-19 surveillance and mitigation plans under the program. So one of the things we might want now are we back that magnified even more during the COVID-19 epidemic. And thank you very much. Great broad strokes of the new strategy. Back to you, Subi.
Thank you, Christine. And we still had a bit of interference on your line, but did hear, that you had questions about dreams, health system strengthening, and the importance of thinking about how to integrate COVID-19 surveillance and programming within PEPFAR. If we missed any of your key points, I know you mentioned something about gender-based violence at the end of your comments. Please do add those into the chat. We'll track the chat comments as well. So from there, let me go to Lejeune.
Yes. Oops. I would agree with Christine that definitely continuing to invest in dreams, but having a pivot where there is more of an emphasis on HIV positive girls, and treatment using a dreams-like platform to reach those girls. The other is, as I said earlier, just that investment in technology. I think that's really, really key moving forward, to invest in electronic devices, or however it is to, for example, mobile ART clinics, having ways that people can use technology to be reminded of appointments and to pick up their medications, to receive messaging. I think that is very, very key as we move forward, because this world, as we learned through COVID, technology has kind of taken us to a completely different level. And I feel that is a wave that PEPFAR should also maximize. The other is the supporting, well, I guess it's related to that, supporting ways that we can fast track the care and the support that we're giving to clients by providing that bridge to technology. Thank you.
Thank you, Lejeune. Let's move to Nyambura.
Yeah, thank you very much. I would like to contribute coming from faith communities. One of the major challenges and where we need a lot of support is that there is increased messages of prayers and divine healing only, particularly because of the increased COVID cases and also the violence in some of the places, which has also increased cases of mental health. So the trend has increased of people seeking help for prayers and divine healing, which is important. But if it is the only emphasis, then there is treatment adherence issues that are affecting most of the people living with HIV, especially the younger people. So this is an area where we are trying to make contribution to bring balanced messages about healing and treatment adherence. But certainly in the next 5 years, if there is increased resources within faith communities, this would be very helpful. Thank you.
Thank you. Really important reflections. Thank you, Nyambura. Mitchell?
Thanks so much. Two thoughts. One, I don't think most people outside of our bubble realize how much PEPFAR has already contributed to the COVID response. When I think about the laboratory platforms, if nothing else. So I think part of this, and maybe it's an adjunct to the actual strategic plan, I think part of this is making sure broader communities understand that platforms already contributed to the COVID response, even before you look to the short and medium term over the next 5 years. I think telling that story is so, so important. And I think the second piece, and maybe this is something, and there's reference, I think, a couple of times to the Global Fund. I think both PEPFAR and Global Fund really not only have a great story to tell over the last 18 months, but also visions of the future. And they're different, perhaps, but what both entities are doing using, really kind of pivoting toward this idea of what we mean by global health platforms. And we hear all these terms, what's the platform? Global health security. I think, again, people get lost in some of the words. I think providing some specificity around what has already happened, and maybe this is a little call out box in the 5-year strategy to say, here's what's happened in the last 18 months that was totally unpredictable or unpredicted in terms of the way PEPFAR and Global Fund were able to support the COVID response. And then here's what the next 5 years look like for not only COVID, but for ideally pandemic prevention and preparedness of the future. And the one other thing I'd say, and it gets back to the very beginning of my comment about innovation, and again, I think people are going to watch. If we let new innovations in HIV treatment and prevention be like COVID vaccines, which mean not available to the vast majority of people in the countries of interest of PEPFAR, then we've actually reinforced that the worst practice, the worst experience. I think there's a chance to really think about what we mean by equity and access, back to Jesse's point, making sure those words have meaning around new technology. Because frankly, if cabotegravir, just as an example, doesn't move outside of the US and Europe through PEPFAR, people are going to look and say, oh, you know what, all these great innovations, whether it's a COVID vaccine or a long-acting injectable for HIV prevention, aren't really possible. So I just would encourage PEPFAR strategy to really embrace a different narrative.
Thank you. Really appreciate that. I completely agree. It's important to share how much PEPFAR is doing to support the COVID-19 response, and also think about innovations in the frame of equity for populations and equitable response. Just checking one more time for any hands, but I think we may be able to move on to question 4. I do see some comments in the chat, and thank you all for continuing to add feedback there as well. But Bob, I'll turn to you for question 4.
Thanks, Surbi. And we're in the home stretch here. And Mitch, thank you. That's actually a great segue to question 4. This is a really proactive group and thinking forward. We have the technical tools to end AIDS epidemic, but inequity, stigma, discrimination, and ineffective policies make our collective job more difficult. So the question we want to hear from the board today is, what specific strategies should PEPFAR pursue to better confront this challenge? And I should correct myself, we want to listen to what board members have to say today. Thank you. And I see Sophia.
Hi, thank you, everyone, and congratulations on the strategy, on this robust process. And I just really want to echo my colleagues on so many of the points made. Just a few additional points. It was really hard to be quiet and to wait till this question to speak, but I felt that this is the question that I probably had the most to contribute to conceptually. So first, I think a much stronger focus on the law and policy environments and addressing the impacts of criminalization, particularly on communities living with and most affected by HIV. And I would really emphasize here the importance of not only legislative and policy reform, but how bad laws are being implemented and investments in the enabling environment, including training of those responsible for implementing the law in ways that really support key populations, particularly frontline healthcare workers. Secondly, civic space is really closing so much in many countries, and so a more explicit focus on civic space and keeping civic space open. And I see that as relevant not only to prevention, which is key, but also to the success of care and treatment. And my other 2 points are mostly about monitoring and evaluation in this space, which is this need to strengthen data collection, but also analysis and reporting mechanisms that can evaluate progress towards addressing human rights related barriers to services, including platforms that enable the safe and meaningful participation of key and vulnerable populations. And this in line with what the Global Fund is doing, but distinct from what the Global Fund is doing. And also in line with that, to be thinking more about differentiated context-specific approaches to monitoring and evaluation that better ensure safe and meaningful inclusion of key and vulnerable populations and these human rights related barriers to accessing service. And I realize that in many ways some of this departs from some of the current PEPFAR metrics, but I would suggest this might be a super important way to go. And with that, I thank you.
Thank you, Sophia, for your comments. I see Christine and Mitch still have hands up. Are those new hands or old ones?
So
Christine?
very old.
Mitch? Okay, thanks, Mitch. Christine, would you like to comment on question number 4?
Thank you very much, Bob. There is the issue of the social behavior change, and these issues we have discussed as the SERB before, and hopefully in the next phase we will be having an opportunity to look through how we can take this forward. Was the evidence around social behavior change? And yes, the level is strong and clear, but what do we do about some of these are outstanding and our behavior in nature and need to be addressed? Thank you very much. Back to you, Paul.
Thank you, Christine, particularly the comments on social changes and behavioral and structural changes that will be so important. And again, please, if you want to add more to the chat, please do so. Let's go to Carlos.
Yeah, I mean, I think, we talked a little bit about this, about political commitment, et cetera. I do think that I worry, as was previously mentioned, about laws that make things difficult. And I see in many countries, laws that are, prohibiting and making legal homosexuality and other things that I just think would potentially derail the ability to deal with the epidemic. I also, again, don't see a lot around substance use, injection drug use, and other ways in which the epidemic is impacting really vulnerable populations, like, I said, persons who use drugs, and also, persons incarcerated in the criminal justice system. And I think we need to make sure that part is integrated, because I worry that, that if we forget about those populations, then their governments are going to forget about those populations.
Excellent points. Let's go to Al and then David, and then we will turn it over to our rapporteur. Thank you, Carlos.
Just to come back to points that have been made, I would encourage strongly that we highlight the incredible successes of PEPFAR, not only over the last 18 months, as Mitch has emphasized, but in fact, over the last 18 years, not just for the HIV/AIDS population and the populations that we're most concerned about, but how PEPFAR has in fact strengthened health systems for broader populations. So I'm trying to address the issue of stigma, discrimination, inequities, etc., and try to get a message more broadly to governments and local communities and nations to say, look, we're investing in this specific area of challenge, but look what has already happened and what we continue to do. So it's not just encapsulating those messages in this plan, but making sure that it flows out to these communities on a continuing basis. As I do believe, as you've indicated in this question, that stigma, discrimination, inequities continue to be a major challenge. And I think to bring out the successes is incredibly important. Thank you.
Thank you, Al. I like that. 18 months, not just 18 months, 18 years, not just HIV, and communicating that well. I'm going to turn it over to David for the last comment on this question, and then we will go to Sarah for a very brief rapporteur session. David, over to you.
Thanks. And I would say that in addressing these issues, inequity, stigma, discrimination, first of all, I'm glad you're putting it up front and center as a big question. I think one way is to, some of the specific things could really be around working on first mile issues of service delivery, and particularly with civil society, and in particular marginalized population groups in civil society, around making access to usable data in forms that they can use, really this data empowerment movement that allows them to use data, plan and make claims on programs, and even further data for building a virtuous cycle. And that means linking civil society with programs, government, and service providers. I think there are also some areas that require attention around the Convergence Agenda, and I like what others have suggested on this. But I think that one way practically is to get involved in country-led processes that address some of these priority cross-cutting issues, really that countries are able to define, and that PEPFAR be willing to contribute tools and funding and adapt tools to address them, and particularly looking for issues, I'd say, around gender and equity, intentional monitoring policies and actions, around poverty reduction plans, and around legal reforms, particularly around human rights-based issues. And then lastly, I would say on that Convergence Agenda, working with global partners to coordinate and harmonize issues around global public goods, again, especially around access to technologies, medicine, diagnostics, etc. Over.
Once again, thank you, David. I'm now going to turn it over to Sarah Clucking, who will provide a rapporteur session for today.
Thanks, Bob. Thank you all. Thanks everyone for all of your wonderful comments. It's, as expected, your reflections were just so rich and thoughtful, and I will try to summarize some of the points today, but my summary is going to be limited by time, going to be limited by my handwriting. So I want to assure you that we have been taking notes and the session is being recorded. So really all of your comments have been captured and will be taken to heart by in the next drafts of our strategy, as well as on into guidance and COP planning years, and as we look to the future and of the PEPFAR program. So I'm sorry, so your voices will be included. I really will, I'm not sure I could do justice, right, to all of our comments all of your comments in just a couple minutes, but I'll focus on a couple of areas. So areas where more granularity could be useful in the chat, many of those comments focused on prevention, right, and ensuring that we're looking at prevention as well as the management of comorbidities and thinking about preventing new infections, but also reducing mortality related to HIV, and then leveraging the PEPFAR platform more broadly, right? And that really was a theme throughout the comments, stemmed through integration with other pandemics, right, to support integration with vaccine delivery, integration with NCDs, but again, always with our keeping the eye on the mission, right, and keeping focused on HIV, but looking to have broader support in the communities and broader support for overall equity, health and equities. So I will leave it there, except to say that I want to mention that we have started the process of pulling together a formal SAB meeting, and we'll be in contact with you soon about that. So keep your eye out for forthcoming information on an upcoming SAB meeting, and stay safe, and thank you for joining us today. So Anjali, can I pass back to you? Would you like to have the final word?
Sure, thank you. Just to really extend a huge thanks. This has been tremendous. Your inputs are critical. We've certainly seen some themes coming through over the several listening sessions that we've had, but this one has been so rich. We're so grateful. And as Sarah said, we're capturing everything. We will be continuing to bring in others and you all in further conversations as we continue to develop this. So again, much thanks, much gratitude. Please stay well, please stay safe. Thank you all.
So Angelique,
Yes.
this is Carlos. If I can say just a final word as PEPFAR SAB chair, you guys have done a great job. I just want to say, and I put it in writing, and Mitchell and I have, we really need the administration to appoint a permanent PEPFAR director. It is not fair to PEPFAR, is not fair to you to be, interim. And we as SAB really require the PEPFAR leadership necessary. And I just, again, it worries me because it shows, it's showing a lack of interest of the administration in this program, and we have to get that fixed. And I want to put that clearly open in the record. I have no problem saying it.
Thanks, Carlos. Noted. I do want to reiterate, though, that this administration has been extraordinarily supportive. And so, from Secretary Blinken participating in our COP process to the president, as well as the two secretaries. So again, we've been very grateful for the administration's support, but your point is well noted. Thank you very much. Thanks all. Have a great rest of the day and a great evening. Bye-bye.
Thanks so much. Cheers all.
Thank you.